Um, I would first like to acknowledge the Yugambeh people, who are the people and the lands on which I'm presenting from at home in the Gold Coast, as well as acknowledge any Indigenous or Aboriginal and Torres Strait Islander peoples here today as well. So I'm going to be talking about designing observational studies for what I've called safer causal inferences. And really, I guess the focus of this talk, the examples are all going to be sort of medical because that's the field I come from, but the principles go across all types of fields where we're trying to make causal inferences. So, if we do something, what happens as a result of that? And so I'll try and tailor this not just to the medical folk in the room, but also go beyond that. And feel free to ask any questions about how this might apply to your work. And so I'm based at Neuroscience Research Australia and the Centre for Pain Impact and UNSW. And most of my work is on musculoskeletal conditions. And recently I've been looking at surgeries and drugs for musculoskeletal conditions like back pain. But this work is all far more broader than that. So a bit of an overview, I'll be talking about asking causal questions, what it actually means, challenges with using observational data to answer these causal questions. And I'll spend most of the time talking about design-related biases and an overview of the target trial framework, which is an approach to help overcome these biases. And at the end, I'll provide a very brief overview of the target guideline, which was a reporting guideline we developed for target trial emulations. So first of all, asking causal questions. I think an area, I'm an exercise physiologist by training, and there's a lot of people who ask this sort of question, are higher levels of physical activity associated with a lower risk of dementia among adults who are over 50 years of age? This is a really common type of investigation people would want to do. And what it might show is that people who are more physically active have a lower risk of dementia. But if we think about how we want to use this information, the goal is then to inform clinical practice or what older adults are doing. And we want to know if they are physically active, what's more likely to happen to them. But is actually just knowing the association of physical activity and dementia actually helpful for a decision maker? Jason's shaking his head, and that's the correct answer. Because clinicians, policymakers, and these older adults might need to know what would happen if they actually recommended doing more physical activity or not recommending that. So if people became more active, what would happen? Rather than just are more active people at a lower risk of dementia. And so we really, when we're asking a causal question, so what happens if I do something or change something, we really want to know what the effect of that intervention is or changing our actions. And so a way to reframe that question would be for inactive people, so people who are not doing much activity over the age of 50, does increasing physical activity compared to remaining active or inactive, reduce the risk of dementia? And this is framed far more closely to what a decision maker is going to have to do. So let's say if that is someone over the age of 50 and who's currently not super active, and they're thinking, my parents had dementia, I'm getting a little bit concerned, maybe I should be more active. This type of question will be far more applicable to generate evidence for that person or to inform their decision. And as most people, certainly in the medical field, know that we'd love to do randomized trials of interventions, because what we do is we get a group of people, so this would be people over the age of 50 who are currently inactive, and we'd randomize them. So we'd allocate them based on the roll of a dice, flip of a coin, to being either active or more active versus, staying sitting on the couch, not doing too much. And then we'd look at the two outcomes under both strategies, and we can compare them. And so what the trial generates is evidence comparing those two strategies. And the way that this works is that enables us to think, if someone does change their behavior, what would happen? And how does that compare if they didn't change their behavior? And it's the contrast between those two things that is a causal effect. And randomized trials are really nice because we know that when we randomize people, there's no other factors that could affect people's outcomes that are going to be different between those two groups because it's random who gets what. Whereas if we go back and if we use observational data, it could be that these people are systematically different, and that's known as confounding. So as I mentioned, randomization is probably the most often thought about strength of a randomized trial, the fact that you get those two balanced groups. But there's also a couple of other strengths. The first of them is there's a detailed treatment protocol. So, we started with this quite vague question of, being more physically active versus not. But actually in a trial, you'd probably compare seeing an exercise professional, like someone like an exercise physiologist or physiotherapist for, maybe 5 sessions over 12 months. And they might help coach you try and increase your physical activity up to a certain level. The World Health Organization recommends about 150 minutes a week. So maybe we develop a bit more of a comprehensive treatment program and ask people to adhere to that versus maybe doing nothing. And another benefit is that we begin following people up at the point we randomize them and assign them their interventions. And this is something that most people in trials just take for granted because it's the way it works. And what this enables is that everyone's the same at the start before they have any interventions. And then we get to follow them up and see what happens from the point at which they start taking either treatment or undergoing either intervention. And this means that any potential causes that come from those interventions, or effects rather, are going to be captured. We're not going to miss anything, and there's not going to be any systematic differences between those groups. And this will make a little bit more sense when we talk about observational data. So if we wanted to run a randomized trial for this, it could be quite tricky because dementia's not that common of an outcome. And if we were going to randomize people, let's say at 50 years old, it might take quite a long time for these people to develop dementia. And therefore, also for exercise or physical activity to have any effects. So we need a really long follow-up period and a lot of people to be able to actually detect a difference between these two groups in outcomes. And so, we might need 10,000 individuals. There was a large trial of exercise that was trying to look at all-cause mortality, and I think they had about 6,000 individuals over a 5-year follow-up. But they were quite old individuals because they needed to have a moderate likelihood of the outcome. So really, I think investigator grants in Australia just came out the other day, and I think a lot of people would have been quite disappointed because funding in Australia and across the world for trials and research in general is really difficult to attain. And so when you think about all the good research that needs to be done, is this trial that would probably cost $10 million, maybe more, because you'd need staff to follow people up over such a long time. You'd need a lot of people, you need to deliver the interventions, etc. Who's funding this? It's probably unlikely we're going to be able to actually run this trial. So what do we do here? We can either just say, well, we don't know. These older people who are not too sure about what to do, we unfortunately can't provide any evidence because we can't run a trial. I don't think that's a great answer. And so the next, if you think about an evidence pyramid, you've got randomized trials at the top, and the next step down is observational research and observational studies. And so there's many reasons why we can't run trials. Some of them being like those I just explained, they're expensive, they're impractical. If we run a trial of 10-year follow-up, it's not going to produce timely results. We're not going to know until 10 to 15 years down the line. And in vanishingly rare circumstances, I think some trials can also be unethical. I think the example that most people give is smoking. These days we certainly couldn't randomize people to smoke or not smoke. But I think in almost all circumstances, we can actually run trials. There's a really nice example from the UK where for people who had a heart attack out of hospital, so these are people who are, essentially have died out of hospital, they wanted to compare giving adrenaline versus placebo. And these people weren't able to consent, but they managed to devise a way that there was enough clinical uncertainty that they were able to waive the consent and still conduct this trial in an ethical way. And so even that, which sounds quite unethical, it can actually be conducted appropriately. So I think trials should be done when they can be, but when they can't, we have to rely on observational data. And today what I want to talk about is how we can best do that so we're not misled by our data. And as I've already alluded to, there's some biases that are related to the fact that observational data is not randomized. And the main one is confounding. So we want to see the effect of physical activity on dementia. But if we just compare people who are physically active versus people who aren't, we're going to have these other factors that might also be related to why they're doing their physical activity. Could be they have a better diet, they have more free time, maybe they're really wealthy, they've retired at 50 and they've got heaps of time to play golf. And these things are all also going to affect the risk of dementia. And so these are known as confounders, and we can't be sure that these will be the same between the groups. And in almost all circumstances, they're not. And this can bias our results. And there's also measurement error. In observational data sets, particularly data sets that are already existing, we aren't sure how things measure. In trials, you have very close control over how you measure things, and you take a lot of care to do it well. But in observational data, we're never confident that things were done as we thought they were. And you can address confounding by measuring all these variables and adjusting for them. There are many statistical approaches that you can use to do that. But the key challenge is you can never know that you've addressed confounding completely. And I actually don't think you ever can completely address confounding. The best you can probably do is eliminate most of it through this adjustment. But this is the key challenge. But if you have a really rich data set, maybe you can get pretty close. And so I'm going to give a bit of a case study. So again, this is a medical example. And I can see Barbara on screen. This will be one that she'll like. But in the late 90s, there were a lot of observational studies on this question. So looking at postmenopausal estrogen and progestin, so hormone use for women who had undergone menopause or undergoing menopause. And people wanted to know the risk of cardiovascular disease. And so this observational study showed that among women who took estrogen with progestin compared to women who didn't use these hormones, the risk ratio was 0.39 for having a cardiovascular event or coronary heart disease. And so that is a 60% reduction in the risk of heart disease, which, if that's true, that's like every woman should be getting this treatment because it's incredibly effective. But when we have such large effects, you really have to question what's going on here. And later on, in the early 2000s, there was a randomized trial, a very famous randomized trial now, that randomized people to either hormone therapy or placebo and followed them up over 5 years. And they found actually a very different result, which was a hazard ratio of 1.24. So that's about a 25% increased risk of heart disease. And so there's clearly a difference between these results here. And the interpretation of this, most people trust the randomized trial, first of all, because we know it's not confounded. Trials are generally the highest quality of evidence. And we'd assume that the observational study is wrong because of confounding. And that's what most people think about when they think about the flaws of observational research. And that is a very valid thing to think, right? But there's also other biases that can affect the design of a study that observational studies are often subject to. And one of them is prevalent user bias, and another is the creation of immortal time. And I'm going to briefly touch on these, what they mean, but they're both forms of selection bias that often people conducting observational studies introduce inadvertently because they haven't got that clear time point where people start the interventions, like they do in a trial. So to illustrate the effect of these, we've got these same two studies we had before. We've got the randomized trial, we've got the observational study. You don't need to read the abstracts, I know they're very small. And then there was another study that came out later in the 2000s, 2008, I believe it was, that actually used the same data as that previous observational study. But they designed the study differently. they compared people who initiated hormone therapy versus people who didn't initiate hormone therapy. And you remember in the trial, that's what you do. You randomize people to start the intervention or start the placebo or not start the intervention. And that was the key difference between these two observational studies, is they've designed who they've included based on this initiator versus non-initiator, whereas the previous observational study just compared women who were taking it versus not, like our first question about dementia. And they adjusted for the same confounders. So confounding isn't the reason for different results, but what they found was a hazard ratio of 1.42, with obviously quite wide confidence intervals, but clearly 0.39 is very different to 1.42, and 1.42 is far closer to what was found in the trial than what was found in the previous observational studies. And so by designing the observational study differently, it appears they reduced those biases to do with study design, which is clearly what affected these results most, rather than actually confounding. And these biases are really common. 61% of recent drug observational studies of recent drug interventions published in 2022 had at least one design-related bias. So this is those prevalent user bias, post-treatment eligibility criteria, model time periods. The details of these don't matter just yet. But really, those studies were 2000, 2008. These issues are still really common. And one thing we know is we can avoid these by emulating the design of a randomized trial, as was done in that more recent observational study of hormone therapy, to avoid these. So just briefly, as I said earlier, RCTs were created as a method of causal inference to learn, if I give intervention A or B, what happens on average? And this is facilitated by having a clear time zero. And that's the time at which people become eligible, that they are assigned treatments and follow-up starts. So in a trial, this is really clear. It's when they get randomized treatment, because they have to be eligible to be randomized, and then they get the treatment and follow-up starts at the same point. So everything that happens to them after they start treatment is captured. But when this same thing is done in observational studies, a really common issue is that eligibility criteria includes things that actually happen after time zero. So this might be, for example, if we, and it'll come up in a later example, if we want people to use a treatment for 5 years, we want to know what the long-term use is, and we only include people who use that treatment for 5 years, what happens is we create a time period, that 5-year period, ourselves, where people can't actually ever have the outcome of interest, because it would mean they'd stop taking the intervention, or they'd have the outcome and therefore would be ineligible for that reason. So we create this little population where they've been able to take this intervention for 5 years and not have the outcome. And that's a fundamentally different group of people to everyone who starts the intervention, because they might have adverse events, they might have the event of interest, etc. And another one that's often related is treatment strategies start actually before we follow people up. And so that could be the same thing here, because that excludes anyone who's susceptible to the effects that arise at the start of treatment. People go to the doctor, they get prescribed a drug, and maybe that drug doesn't work for them, or they have a side effect. Often that's going to happen pretty early on. So they'll stop that, and then what often happens is those people are excluded from our analysis. So these are both creating selection biases that really can have big effects. I want to bring us back to another example, because I think it's easier to understand it when we talk about it in context. So if we're looking at the effect of statins, which are a cholesterol-lowering medicine, on the risk of cancer. So this is not what the treatment is designed for, but people were interested, maybe there was some effect. There was a clinical rationale that why this might be possible. Again, observational study published in the New England Journal of Medicine, best medical journal out there, back in 2005. And what they did is they did a lot of good things. They adjusted for a lot of confounders, so things like other drug use, physical activity, the cholesterol levels, family history of colorectal cancer, vegetable consumption, diet, a lot of really important things to assess confounding. And they also aim to reduce measurement error because they did a sub-study looking at self-reported statin use versus what they collected in their observational data. So, they were really confident they'd avoided these data-related problems, the confounding measurement error. But this all sort of fell over when they included people who used statins for at least 5 years compared to people who didn't use statins. And funnily enough, for those people who were able to use statins and were probably just healthier in general, there was an odds ratio of 0.5. So a halving of the odds of getting colorectal cancer. And so what they did is they included prevalent users, people who are already using statins because they had to use it for 5 years. And they created this period of immortal time where nobody in that statin group could have cancer for 5 years. So, anyone susceptible to getting cancer or having an adverse effect from the statins and stopping using them would be removed from that group and included in the statin non-use group. So we're creating two very different populations that we can't adjust for. And I think that's the key message of this talk, is you can't adjust for these reasons. You need to design the study in a more appropriate way. And so the way to do that is through target trial emulation. And that's a two-step process. First of all, it involves specifying the target trial, which involves in detail describing the protocol of the randomized trial that you would conduct if you could, that would answer your question. And what that involves is something like this, which is involving describing the eligibility criteria, the treatment strategies that you'd compare, the assignment procedures. And so in a trial, this would be randomization, the follow-up period, which, as we know in a trial, will start from when we randomize people, the outcomes, the causal contrast, which is just you're looking at the intention to treat effect or the per protocol effect or the effect of adhering to treatment, and the data analysis plan. And so once you've designed this trial, regardless if you can actually do it in practice or not, it gives you an anchor to design your observational analysis around, so you can adhere to those principles. And the next step is then emulating that target trial, and that involves mapping the design of the trial that you just designed that would answer your question to the data that you have available or that you wish to collect. And so this allows us to avoid those design-related biases that just don't occur because of the design of a trial. The key thing here is we still have confounding. We can't magically emulate randomization retrospectively. But what this does is it leaves confounding as the main problem for us to deal with. And it, by design, helps us avoid all those other challenges that those previous observational studies suffered from and had really big effects on the outcomes. So just to walk you through this, I'll try and speed up a little bit. If we go back to that statin example, do statins reduce the risk of colorectal cancer compared to not taking statins? Colorectal cancer is pretty rare, and it's a long-term outcome. And so we're probably not going to be able to do a trial. So we have to conduct our observational study. Then our target trial, very simply, might look something like this. We've got eligibility criteria. We'll include, let's say, everyone aged 18 to 80. We'll compare statins to usual care, so not taking statins. We'd randomize people, ideally, follow them up over 10 years. Our outcome would be a diagnosis of colorectal cancer. We'd compare everyone who was assigned, and we look at a 10-year risk ratio. And then the next step is to map that to our observational data. So obviously, this isn't a study I've done, but we could ascertain who are adults by looking at their health records or birth certificates. Then we can look at treatments. We might have some sort of claims database where people, get reimbursed for their statins. So we can ascertain when people started their treatment. We would assign people based on what they received in practice. So this is a key difference to our target trial and something we need to overcome because there's likely confounding here. Follow-up would be the same. It'd start at randomization and go for 10 years. A diagnosis might come from health records as well. And there's a little bit of a nuanced difference here, but we try and ascertain what happens if we assigned people to statins or not. So like sort of the analog of the intention to treat effect. And then our analysis is going to be quite different because we now have to adjust for confounding because we don't have randomization. So we might do propensity score weighting or something similar with variables that are all measured at treatment assignment, so before people actually get treatments, and then we'll estimate the adjusted 10-year risk ratio or risk difference. So you can see here that most of this is the same. And, our follow-up is the same, our eligibility is the same, and treatments are the same. But there are some other things that we need to handle a bit differently. And I guess this is the key message is we want to keep the design of the randomized trial as similar as we can to our observational study. So what happens when these biases are avoided? Here is a reanalysis where someone actually did the target trial emulation of this question, published in Nature Medicine back in 2019, and as a QR code to the paper here. And they emulated a target trial and followed up everyone from when they started taking statins or didn't. And the results were, you'll remember, the RCT had an odds ratio of 0.5. This found a hazard ratio of 1.04. So basically no effect of statins on cancer. And that difference is not due to confounding. It's not due to, differences in measurement error. It's due to the design of the study. And so I think that's a really critical thing to take away here. And this was similar to later RCTs and meta-analyses that got conducted. So some key considerations for this, the final target trial must still be theoretically possible to conduct. So, you don't need to actually have ethical approval or, be able to feasibly do it, but follow-up must start when eligibility criteria is met. You can't, in a trial, randomize people and then retrospectively try and figure out if they're eligible or not. So the same thing has to be true here. And you can't use variables that are measured after the start of follow-up to define either eligibility or treatments, because again, you can't do that in the trial. And doing so introduces these design-related biases. And then it's really critical that you map that observational study really closely to your target trial. And if you can't do this because maybe you don't have the right data, you might be necessary to use a different data source that has more information. If you can't do that, maybe the best option is actually to not proceed with the observational study, because you know that you're going to have some of these design-related biases, and it's really difficult to quantify what effect they'll have on your results. And the last option is maybe the only way to answer the question that you're interested in is to just do the trial. And I think a common scenario this is relevant to is when the treatment isn't used in practice. So if drug companies aren't able to do these unless they prospectively collect it, in which case they should just do a randomized trial. But sometimes doing a trial is the only way to answer your causal question. So in summary, observational studies are frequently limited by these really avoidable design-related biases, and it has really large impacts on the results. And target trial emulations are quite a powerful framework that can help us avoid these design-related biases, but it doesn't, I think this is probably a misinterpretation from a lot of people, is it doesn't actually help us deal with the confounding, directly at least. And so that's really where we need to focus our efforts after we've designed our target trial. We need detailed data on the timing of eligibility criteria, the start of treatment, and outcomes, because we really need to recreate that sequence of events. And we can't use information that occurs after baseline to assign eligibility criteria, treatments, or adjust for confounding, because then, again, we couldn't do any of this in a trial, so we shouldn't try and do it in an observational study as well. Very briefly, I'll spend 5 more minutes on this. Target trial emulation has really taken off in medicine. Every major general medical journal has now published something on it, except The Lancet. But it's really sort of a buzzword at the moment, which I think there's pros and cons to, but everyone seems to think it's helpful. And the studies that are published are increasing annually. So there are about 800 published in 2025, which to me is terrifying because I've read a lot of them and a lot of them are not very well done, but they're really popular. Journals have identified the framework as being useful. JAMA actually suggested that maybe, we can interpret the effects of observational studies as causal, which anyone who knows JAMA is quite a controversial thing to say. Regulators as well, such as the TGA here in Australia or the FDA in America, are reviewing the use of observational data to inform their decision-making. And NICE over in the UK and the European Medicines Agency actually now advocate for anyone using observational studies of interventions to estimate a causal effect to use the target trial framework. So this is something I think that's going to be here to stay. Very briefly, we developed a reporting guideline for this. For analysis of observational data that aim to estimate causal effects by emulating a target trial. And we did it following the Equator Network's sort of very formal structure, which has 5 stages, and that culminates in the publication of the reporting guideline. So briefly, we conducted a review to assess what the actual state of reporting was like back in 2023. And unsurprisingly, we found that it wasn't very well done and very inconsistent. So we needed guidance to help people to report them clearly. We conducted a Delphi study, or a slightly modified type of Delphi study, with 18 experts in the field, and then had a consensus meeting over in Boston to finalize the guidance, which we then piloted with just under 110 different users of the guidelines. So this is PhD students, epidemiologists, regulators, etc., and then published the statement. And we did that last year in September in both JAMA and the BMJ, which was really nice. And you can see the website that we've put together in the QR code, and there's a link to the guideline there, but I can pop it in the chat afterwards as well. And the website also has other materials that will help people clearly report these studies. So things like an editable checklist, like you'd get from Consort or Prisma, participant flow diagrams, and target trial protocol tables to really cleanly summarize what the target trial is and how you've emulated it. And very briefly, target might be used in practice by, first of all, authors, planning, conducting, or reporting observational studies of interventions to make sure that they've got all the information we need to read these studies and appraise them. Peer reviewers or journal editors might use it to help review a manuscript and require all authors to follow the checklist, so that all the information is reported, and teachers might use this to help highlight key design and reporting features of these studies. So yeah, I've already said a lot of this, but Target aims to standardize what's being reported, but not how you should do a study. I think if you're aiming